Dr. Martin Shapiro. He is a professor of medicine at Weill Cornell Medical College, and he's a distinguished professor emeritus of medicine and public health at UCLA. At UCLA, he had served as the division chief of general internal medicine and health services research for 25 years. His research has focused upon access to and disparities in care. So today he's going to present on racial, ethnic, and socioeconomic disparities in care for hepatitis C. What do we know and what do we need to learn? Dr. Shapiro, take it away.
Thank you very much. First, my colleagues and I want to thank NIH and NIDDK for funding our study on disparities in diffusion of direct-acting antiviral meds for Hep C, now in its first year. Next slide, please. John Donne wrote, "Any man's death diminishes me because I am involved in mankind." HCV is a problem of utmost urgency. Over the last decade, annual acute cases have tripled, are occurring largely in persons aged 20 to 39, and are 2.8 times as common in indigenous peoples as in non-Hispanic whites. In 2018, over 137,000 chronic cases were newly reported by 37 states. This acceleration is being fueled by the opioid epidemic. The problem is not going away and is being exacerbated by the pandemic. Next slide. Chronic infection is more than twice as common in African Americans as in whites. Rates vary in Hispanic subpopulations, and estimates for indigenous peoples vary widely but are substantial. Next slide. More people die of HCV each year than from any other chronic infectious disease, including HIV. Since the introduction of DAAs in 2013, there's been a slow decline in annual deaths, but total deaths from 2014 to 2018 exceed 90,000. Next slide. Blacks are almost twice as likely to die as whites. Even though prevalence is lower in Hispanics than in whites, their mortality is significantly higher. Indigenous peoples have the greatest mortality and have improved the least since 2013. More than 10% of the deaths since 2013 represent excess deaths in Blacks, Hispanics, and indigenous peoples relative to whites. Next slide. Of course, all these 90,000 deaths are of concern. Why are so many people continuing to die from Hep C? Are none of these deaths avoidable? Is this all a manifestation of the patient's disease, or is it also related to system, provider, and patient factors affecting receipt of care? Next slide. The science of studying healthcare depends on methods that are no less sophisticated than those of molecular genetics. This model is a little different from the one that Eliseo presented, but it has many of the same elements. Our conceptual model in our study takes account of predisposing, enabling, and need variables that can affect use of care and outcomes at the individual, interpersonal, community, system, and society levels. Next slide, please. Among Medicare beneficiaries through 2016, Hispanics, women, persons with lower incomes and less education were less likely to receive DAAs. That was also true for African Americans in 2014, but not after that. Next slide, please. Other potentially relevant issues in terms of disparities include Blacks being less likely to be listed for or to receive liver transplants, and receiving less care and having inferior outcomes for hepatocellular CA, as Dr. Setyawan indicated, as well as differential care for opioid users, Medicaid beneficiaries, and the uninsured, the high cost of medications, and at least until recently, the issue with prior authorization in Medicaid and some other insurers. Next slide, please. Studying problems that impede HIV or HCV eradication and that perpetuate disparities in sufficient detail to be able to design, test, and implement Interventions nationwide to address them would require collection of unbiased and detailed national data from patients, clinicians, and medical records. HHS invested heavily in efforts to optimize care for persons with HIV in the late 1990s. Among other efforts, they contributed $24 million to the HIV Cost and Services Utilization Study, but also received other funding. I was fortunate to be the PI of that study, and I will talk about it briefly because it illuminates what that kind of health services research and community-engaged scholarship can contribute to formulation of informed health policy, as well as how rapidly it is possible to make progress in addressing a serious problem. Next slide, please. To produce unbiased national data, HCSIS used a three-stage PPS probability sample of people in care in early 1996. The stages were communities, practices within communities, sampled based on caseload, and patients within practices. The inverse of each patient's probability of selection was their weight in the national estimates. Hundreds of practice sites were involved, ranging from large public hospitals to individual practices. Next slide. 13 research teams with about 70 investigators nationally were assembled to study many issues, including viral genetics, treatment access, patient behavior, provider attitudes, and mental health. There were community partners on all of the research teams. Next slide. We were able to track diffusion of HART treatment during its first 2 years of availability. Progress was spectacular, reaching over 85% of patients during that time, but it was uneven. Men did better than women. Next slide. Whites did better than Blacks or Hispanics. Next slide. And those with private insurance did better than those with Medicaid or who were uninsured. Next slide. Other findings pertinent to health disparities in HCV included many went without care because they needed the money for food, clothing, or housing, lacked transport, or could not get off work. Those who had care managers, often through the Ryan White program, were more likely to get HART therapy. Blacks were less likely to be enrolled in clinical trials and waited much longer for HART than whites unless they saw Black physicians. And generalist physicians who considered themselves to be HIV experts provided care comparable to specialists. Study findings supported the reauthorization of the Ryan White Care Act, which currently receives about $2 billion annually to support HIV care. Next slide. In our current project, a multidisciplinary team from several institutions in New York State and Alabama are studying diffusion of DAAs. We are analyzing Medicare and Medicaid data by race and ethnicity and by neighborhood measures of social determinants of health. We also are interviewing and surveying patients at diverse sites in New York State and Alabama, as well as generalist and specialist providers throughout New York State and in Alabama and some adjoining states to identify patient experiences and barriers to care and provider factors accepting receipt of care. Next slide. We've adapted our study to the changing national testing and treatment guidelines. We'd originally intended to study care for baby boomers, but now include all adults. And we've expanded our Medicaid analyses from 2 states to all 50 plus DC, and have expanded primary data collection to include opioid treatment programs. Next slide. We will explore an array of patient-related factors, including stigma related to HCV, HIV, and opioid use, perceived discrimination, trust in medical providers, beliefs about HCV and its treatment, access and barriers, including insurance denials, distance to travel, availability of specialists and language spoken, competing needs, life chaos, insurance type and characteristics, or lack thereof, mental health and substance use disorders. Next slide. We also will explore such provider and system factors as whether they accept the patient's insurance, attitudes to persons with HCV, HIV, and opioid use disorder among providers, HCV knowledge and experience of providers, confidence in their ability to initiate DAAs and monitor treatment, specialty access, and specialists' perceptions of the opportunity cost of providing care for this condition. Next slide, please. Our study should provide useful information about recent patterns of care for patients with fee-for-service Medicare and Medicaid throughout the US, and insights about provider experiences in a few states and of patients at selected sites as to why some patients are not receiving the care that they need. However, it will not provide nationally representative data on why disparities persist and people are dying in the numbers that they are. Next slide, please. A decade ago, Brian Brink, the chief medical officer of Anglo American, the multinational mining corporation based in South Africa, set an aspirational goal for control of HIV: zero tolerance for new HIV infections, or for opportunistic infections, or for deaths from HIV. Can't the United States do at least as much for HCV? To accomplish this, we need more than abstract targets. We need the resources to collect data that will allow those targets to be pursued on the basis of ample evidence. Next slide. We urgently need comprehensive data on patterns of testing and treatment for HCV and treatment for end-stage liver disease, cirrhosis, hepatocellular CA, and patterns of use of liver transplantation. We need to understand patient, provider, system, and societal factors contributing to these patterns of care. And we also need well-funded intervention trials in all populations to optimize care and outcomes, and implementation studies to assure findings are applied widely. Are intervention trials to improve care and implementation studies the business of agencies that fund health research? Shouldn't those be left to health systems as part of their QI programs? I think not. The goal of health research agencies is not only to make fundamental discoveries, but also to assure that knowledge is applied to enhancement of health. Toward that end, governments have to play a central role in planning and financing such studies, which are as essential a part of health research as the development of drugs and vaccines. Next slide. This model developed, I was involved in developing in collaboration with Robert Kaplan, the former Associate Director for Behavioral and Social Sciences at NIH, and Arlene Brown of UCLA, illustrates why this kind of work is needed. To get from risk or disease to optimal health outcomes, treatments are needed that might be biological, social, behavioral, cognitive, or environmental. And one of the first orders of business is to assure that all persons who need these treatments are getting them, and if not, why not? Health services research generates data on outcomes, costs, and disparities. When research is community engaged, it can provide textured information on the full range of barriers, beliefs, and behaviors that may impede adoption. Such studies provide evidence that can inform implementation studies to increase adoption of treatments in order to improve outcomes and diminish disparities. They also inform the design of new treatments or interventions when the existing ones are insufficient to the task. These implementation and intervention studies need to be conducted with greatest rigor in all populations who stand to benefit, with community buy-in and with careful measurement of patterns of care and of social, medical, and economic outcomes. When problems cannot be solved at the level of patient, practitioner, or health system, the needed treatment may be policy change, perhaps in the form of something like the Ryan White program, informed by this kind of work. Our study and some others are attempting to contribute knowledge that moves us down this path for HCV. We might say that health research agencies everywhere should take as their maxim that any person's avoidable death diminishes them because they are involved in humankind, that their application of knowledge always should include partnering with communities as well as clinicians in health systems, and that they will appropriate sufficient resources to identify and address effectively all of the impediments to full adoption by all populations of treatments and other interventions that can enhance health. Thank you.
Thank you, Martin, and thank you to all.